Hey there, welcome to the home stretch. Conditions Lecture 3, Part 2 of 2. All right, so we talked about autism, ADHD, and intellectual disability. And now we're going to move on to specific learning disorders. Learning disorders have a particular set of diagnostic criteria in the DSM-V, and notice that every single disorder in this lecture is from the DSM-V, right? So we contrast that with the ICD, the International Classification of Disease, 10th edition disorders, which we talked about earlier. So learning disabilities. Dysfunction in neuropsychological systems that affect school performance. So it's pretty clear. It's associated with the occupation of education. Then when kids are grown up, of course, it can affect work as well. There's difficulty with reading, spelling, writing, or math, and these are different particular learning disabilities or disorders. Academic skills are below age expectations, and it's based on a discrepancy between academic and cognitive skill. So, academic performance, low. Cognitive skill, normal to high. So, this is a hallmark. It's also important for us to be aware of this when we're working with clients who have learning disabilities, that they have solid cognitive skills. However, this one area is problematic. The difficulties start during school age, and there is a fair amount for you to read from the DSM in the presenter notes. So do have a look at that. Some common types of learning disabilities: dyslexia, which is associated with reading; dyscalculia, associated with math; dysgraphia is writing, and we specify the severity according to the DSM-V, either mild, moderate, or severe. Now we're going to look at a condition called nonverbal learning disorder. It's actually not in the DSM-V, interestingly, and there's an article about it that's linked in the presenter notes if you want to know more. We see this pattern in kids that OT often gets referrals for, and here's the pattern. There's deficits in nonverbal reasoning, right? So they can talk up a storm, but when it comes to solving problems with the body, there is some difficulty, some frank difficulty. There's weak visual, spatial, and visual discrimination abilities, poor organizational skills, that should not be poorly, difficulties with inferences and abstract reasoning. So high-level executive functioning, also difficulties with mathematical reasoning, and limited social competence. So just to keep in mind that this is a pattern that we see, and the rate is about 0.5 to 1% of the population. Next up, developmental coordination disorder, or DCD. This used to be called developmental dyspraxia, but it's not due to a known neurological insult. So it's not like anoxia results in DCD. It's not due to CP or other muscular diseases. So this is our differential diagnosis. Usually children have the basic skills such as strength and endurance, but they lack the ability to organize and execute skilled and precise movements at the same level as their same age peers or commensurate with their peers. Bilateral control is often delayed, and they can identify the task that requires skill in bilateral control, but they can't actually execute it. Diagnostic criteria for DCD: acquisition and execution of coordinated motor skills is substantially below developmentally expected level. So it's not just like a little clumsiness, it's substantially below. Motor skills deficits significantly and persistently interfere with occupation in all areas. So again, we see that the DSM is considering occupation, right? And we know about occupation. Onset is early in the developmental period, and there is, again, a differential diagnosis so that we make sure that it's not due to something else. Characteristics of DCD. There's coordination difficulties, obviously. They affect the ability to perform everyday tasks. There's a discrepancy between intellectual capacity and motor ability. We might see excessive use of force or poor grading of movements. So that is often due to ineffective proprioceptive function. Okay, so we're bringing up that it's a motor disorder, but there may be a sensory component from the perspective of sensory integration theory, right, which says that we need working sensory in order to inform motor. Bilateral control is often delayed, so that's the last one. Developmental coordination disorder affects 5 to 6% of school-age children, again, more seen in boys than girls. It may occur with other conditions, other developmental conditions, and it may persist into adolescence and adulthood. So here is another prep for class thought question. How might you explain DCD to an 8-year-old with the condition? So what are you going to tell them, right? Let's think about this for a second. They have typical to above average intellectual functioning, but they have all of this clumsiness and incoordination, lack of balance, lack of bilateral control and coordination. So what do you tell this child so that you can work with them and it's not going to start affecting, and at 8 years old, it might already be affecting their sense of self-worth, self-esteem, self-efficacy. And I want you to remember this. If simply practicing motor activities, like doing them over and over and over again, could fix the issues with DCD, OT would not be needed, right? So we need to look at it from a variety of perspectives. And to that end, what other approaches might be indicated? Now, this is a hard question. It's a thought question, right? And it's a hard question, but think about it. What else could you do besides practicing motor? Which definitely we do, but that can't be the end of the situation. All right. So bring your thoughts to class, and the expectation is you will be ready to discuss. Next up and last up is emotional behavioral disorders. And on here we have two different categories of disorder: trauma and stressor related disorders, and then feeding and eating disorders. Again, both in the DSM-V. So in the trauma category, we have reactive attachment disorder, and this is a failure to form effective attachments in early infancy or in toddlerhood. And remember, in our theory lecture, we talked about attachment and the different types: secure attachment, avoidant, disorganized, etc. We can typically see this in adoptive and foster care kids, and those who have had poor social interaction in infancy. Intervention can often be focused on helping the caregiver respond to the child and build on the attachment. Then the other is disinhibited social engagement disorder. And this is there's limited or no close attachment in childhood, and so the child is indiscriminately friendly and may lack appropriate wariness for safety concerns. So they have disinhibition in terms of socially engaging, which can be dangerous, right? And unfortunately, kids who have exceptional needs are often prey for folks who want to take advantage and are waiting to take advantage. All right, that next up are feeding and eating disorders, and we have pica, which is the eating of non-nutritive substances. For kids, sometimes it's little pebbles or rocks, chewing off your erasers and eating them, other non-food items. And then we have two main categories of eating disorder, anorexia and bulimia. And to some extent, these are a little bit beyond the scope of pediatrics. Many people know about them, and we can dig in as needed, but it's important to note that the onset of these two disorders can happen in childhood. So anorexia being a lack of food and eating and associated with severe weight loss, and then bulimia being a binging and purging cycle that is also associated with misperceptions about body image and can also be a way to control weight. Now, that's a high-level overview, but just to keep in mind that these are things that we might see either alone or in combination. And then finally, we have mood disorders and disorders, disruptive, impulse control, and conduct disorders. So first, taking the mood disorders, there's disruptive mood dysregulation disorder, social anxiety disorder, and separation anxiety disorder. So the one that, trying to scroll up a little bit here. Give me one. Oh, geez. Never mind. Okay, I'm just going through it. I'm getting tired here. Okay, so disruptive mood dysregulation disorder. Frequent temper tantrums and outbursts that are out of proportion in intensity or duration to the situation. So this is the kid that will just lose it, right? Because there was only strawberry and not vanilla. Verbal rages and physical aggression towards people or property results, and it's inconsistent with the developmental level. So it's not a 2-year-old who's in the terrible twos falling down on the ground, right? So a lot of presenter notes for you. Please check those out. And the mood between temper outbursts is different, but there's outbursts nearly every day, most of the day, and this child, the profile is somebody who is persistently irritable or angry. Social anxiety disorder, difficulty with socializing in a variety of situations and circumstances. The symptoms can include severe, prolonged crying or tantrums because they're so scared and anxious, become physically immobilized, so a flight or freeze response, shrinking away from other people, extreme clinging, and not being able to speak in social situations. And then separation anxiety disorder is a condition that the child is anxious about leaving their caregiver beyond typical wariness, so beyond not, being slow to warm to strangers or others in their environment, and it compromises interaction in a variety of situations. Last up, disruptive, impulse control, and conduct disorders. The first is oppositional defiant disorder, and this must be present for a period of at least 6 months, and it's the oppositionalness is more severe than that of peers. There's 3 forms: angry, irritable mood, argumentative, defiant behavior, and vindictiveness. So we're not going to dig into it, but again, just as with the eating disorders, I want you to keep these in mind. And then finally, conduct disorder. So this child violates the rights of others and many societal norms. So it's similar to oppositional defiant disorder in some ways, like there's a lot of negative stuff going on, but this child violates others' rights and property rights and societal norms. Examples are lying, theft, vandalism, physical acts of cruelty to people or animals, bullying others, etc. The symptoms have to be present for at least 3 months, and at least 3 symptoms present in the past 12 months, with 1 symptom present for the past 6 months. So scratch that first part about 3 months. 3 symptoms present in the last 1 year, and 1 symptom at least present in the past 6 months. So that is a qualifier for it. We're not going to go into the treatment for all of these, but suffice to say that we may see individuals with a variety of emotional and behavioral disorders. They may layer with other disorders, and they can be very debilitating to children. All right, y'all, you made it through. I don't have a slide because it's the end of the end, but congratulations, you've completed 3 conditions lectures, all the parts. We're now done with conditions, and I thank you so much for your extra work on this, your patience, your attention, and please bring your questions to class. Think about the thought questions across the board, and you can feel free to email me or reach out to me during office hours if you have specific questions. And I thank you so much for sticking with this process. I'll see you real soon in class. Bye-bye, everyone.